Okay, the poll is starting now.
Can you read it, Abdulmalik?
So the first question is, how many times you sit on perfusion side watching their work? A, never. B, less than 10 times. C, more than 10 times. Second question is, do you know from which company your custom back? A is no, B is yes. For the third question, your pediatric cardioplegia, A, blood, B, custodial, D, C, delnated.
عبد الملك لو سمحت شيلني بس ككو هوست عشان اقدر اشارك.
يلا تفضل.
Okay, Abdulmalik, can you see the results?
Okay. So we're sharing the result now. For the first question, how many times you sit on perfusion side watching their work? 7% never, 67 less than 10 times, and 27% more than 10 times. For the second,
I think better for those 7% to go and sit at least watching what their perfusionist is doing. The second question.
Do you know from which company your custom pack? 67% say no, 33% say yes.
I think for a pediatric cardiac surgeon, you should know what is available in the market, because there's certain body weight are not covered by all companies. So you have to know it instead of having a situation that you are not happy about it. Again, more?
For the third question, your pediatric cardioplegia, 60% answered blood, 40% custodial, and 0% with delnated.
Oh, I thought in Saudi Arabia, delnated maybe more than custodial. Anyway, this is acceptable. I use cold blood cardioplegia. It's the oldest and is the more available and the easy to do it, especially when you operate in different hospitals. Then blood cardioplegia is. I use custodial for a few months, 3 years back, but I noticed a depression in ventricular function after that, even in simple cases. I think it's not because of the custodial is bad, but maybe the storing and bringing it from outside without proper temperature control for it made this. This is the needle is an easy to do. Nowadays, many pediatric cardiac surgeons are using it. I hope next time we see a different answer for the needle. Thank you. Can we start the lecture, please? Assalamu alaikum. The principles of cardiopulmonary bypass in pediatric cardiac surgery, I assume with this lecture that you already got a series of lecture about cardiopulmonary bypass during your training, and then yes, I'll concentrate only mainly on pediatric aspects. Why? Let me ask a question. Why pediatric cardiac cardiopulmonary bypass is different from adult? What are the reason it's different from adult? Can anybody answer? Anybody?
Yes, sir. In
Yeah.
adults, the physiology is consistent in most patients, except for a few patients with other congenital lesions. But in pediatrics, the physiology is different between.
So a variability of the anatomical variability. Is that right?
Yes, and physiological also.
A surgical variability or anatomical.
Yeah.
The second, what kind of variability usually we see in pediatric that we don't see in adult?
Shunts.
Shunts, excellent. Shunts are probably the most important thing.
Yeah.
Still, other many things when you do a different approach to aortic arch or a single ventricle, you need to go into a different part of the body that the adult cannulation usually don't go there. What else from the variability and anatomical and surgical?
Cannulation strategies is different.
Okay. What about priming volume?
Yes, the priming volume will affect the pediatric population more because of their low blood volume. So any extra crystalloid, for example, will cause significant dilution and will affect the physical capacity more than adults.
Okay. What is usually the prime volume for adults? How much percent?
20-30% of the whole prime.
Excellent.
Plus, yeah.
What about pediatric?
Pediatric, we try not to prime with any extra fluid. We try to prime.
No, but the prime.
Yeah.
Whatever. How much you need to prime the? If you calculate the prime volume to the baby blood volume, how much?
I'm not sure.
Is around 200.
Can reach to. Okay.
Yes. Can you reach to what?
Yeah, I will say 200.
200, sometime to 300, depending on the. This is why it's a totally different priming technique that we use in pediatric than in. Anyway. What I'm going to do to give you the trends and updates in cardiopulmonary bypass setup in pediatric cardiac, but I will make it more of clinical scenarios, inform question and answers. First of all, 4 months old tough with what is abnormal in his chest X-ray? Anybody can answer?
Boot shape heart.
Yes. What else? Four months. Is this a normal upper mediastinum for 4 months old?
There is also decreased vascular markings, which indicates decreased pulmonary blood flow. And
okay.
And hyperinflation of the chest.
Okay. I think
the upper mediastinum, not
yes,
sure of them.
That's what I'm looking for.
Absent thymus.
Absent thymus, excellent. What absent thymus give us? What kind of disease? We see it associated with absent thymus.
DiGeorge.
DiGeorge syndrome. Why DiGeorge syndrome is important for us?
Because decrease associated with low immunity and low calcium.
Low calcium. So, okay, what is special in pre-op consideration for them? Of course, if you see this, you ask to investigate for a DiGeorge syndrome. I will not go on the investigation of DiGeorge syndrome and what kind of chromosome is affected. But what special preparation you consider?
Maybe
you can give them eradicated blood, so you
eradicated?
Eradicated blood, yes.
Irradiated.
Irradiated blood.
Okay, so the blood is a very important. We give them, we prepare irradiated blood 24 hours before that. Why?
Because you will if the WBCs, if there is any WBCs that will increase the host reaction.
Yeah.
So because host reaction.
What kind of hosting? Is a special type of WBC, is a T cell, but we will not go in that. But what we call this reaction?
Hemolysis. Host versus
No,
graft
no.
will cause hemolysis.
What again? You said it.
Host versus graft.
Graft versus host. Graft versus host reaction, because the graft, the blood itself start to attack the body, the WB cells, and the transfuse attack them. It's not only in the blood. There are recorded cases from fresh frozen plasma. So this is why we ask for an irradiated blood to be given. What is the problem of irradiated blood if you give it in the priming of a baby like this? What's the main side effect? Hyperkalemia. Hyperkalemia. So you have to give a time for the perfusions to prime and to do a pre-bypass muffing. Anyway, it should be irradiated blood, cytomegalovirus negative blood. So you have again to ask also for cytomegalovirus test for the blood unit itself. Anyway, that we talk about it. When we use a prime blood in the prime, low body weight, especially less than 10 kg or even more to less than 5 kg. When we have a low hematocrit, because hemodilution is. So how you estimate how much blood you give? According to what? Shabab.
To body weight.
Yeah, but finally, what is our aim? The predicted hematocrit on pump. So, is that right? That we give blood, so our hematocrit should be more than 25 when we started the pump itself. We can give a whole blood, we can give a backed RBCs, or we can give backed RBCs plus fresh frozen plasma. The first and the last and the third is the most commonly used. Some units, they use fresh whole blood, which is probably the best, but availability is stress on the blood bank is quite large. What are the side effects? Infection, transfusion reaction, immunosuppression, all immunization, strain on the blood supply and the blood. So priming the machine, we need to prime to get rid of the fluid and the air. In adult is around 25 to 30%, and in pediatric it can be up to 300% of the patient's blood volume. Other priming solution, crystalloid priming solution like lactated ringer, plasma light, or colloid priming solution, especially albumin. Other special consideration in DiGeorge syndrome. What are other problems? And you just mentioned it, Abdulmalik. Hello.
Hypocalcemia.
Hypocalcemia is an important issue, but generally what we do in the prime, we add some plus the blood, crystalloid, colloid. We add what we call it additive. This additive include calcium, mannitol, and bicarbonate. The calcium.
Yes. ناقش معك دكتور حسين قطان الصغير من الجامعي، صوته شبيه شوي لصوت دكتور عبد الملك.
ما في مشكلة. الو.
اتفضل دكتور.
اي priming solution additive is calcium, mannitol, and bicarbonate. Even though you have to watch in DiGeorge syndrome, the hypocalcemia, the effect of mannitol and bicarbonate is quite controversial. But the proper answer during the exam said whatever your center is doing. So you have to know, is your center adding bicarbonate or not adding bicarbonate, calcium and mannitol? You have to know your priming in your center, and then the best answer say that this is what we are doing. One thing which is important if it comes to the exam to you is what kind of pH stat you are using in your center. Hello.
It's different from pediatric and adult.
Adult, okay.
An adult usually we use alpha stat.
Excellent. And pediatric? Again, usually we use alpha stat. When you need a pH stat?
And hypothermic circulatory arrest.
And hypothermia, especially deep hypothermia or deep hypothermic circulatory arrest. Why we need it?
It will affect the autoregulation of the brain, blood to the autoregulation of the blood to the brain, and
it has been found if you use a pH stat, the brain gets perfused uniformly without preferential flow to one part of the brain. What we use in pH stat, ya Shabab? What we add?
Bicarbonate. CO2, sorry, CO2.
CO2, excellent, CO2. We add CO2 to maintain the temperature corrected pH around 7.4. Alpha stat, we keep it 7.4 regardless whatsoever. You send the technician to the AB machine, and the AB machine does it around 37 degrees centigrade, and then they give you the answer. Then you correct whatever there according to keep balance the pH around 7.4. In pH stat, you corrected it according to the temperature that patient is on. So there is a special normogram that fix it from different temperature. So you fix it around 7.4 at that temperature, not at 37. If you warm it at 37, you give you what, Shabab? Abdul Malik? Give you alkalosis. Natural. This is why we add CO2. This is the prime component, plasma light, albumin. This is in our unit, 25% fresh frozen blood, if it's available, or backed RBCs and fresh frozen plasma. We add calcium, sodium bicarb. We don't add mannitol regularly. We give heparin, Lasix, cefazolin, and solimodrol. Case number 1, after receiving heparin 400 units per kg, ACT is 180. Second, what do you call this?
Heparin resistance.
Okay. What are the causes? We said heparin resistance. What do you do?
You give second dose of heparin, and if it's not getting the ACT more than 400.
Before that, there are 2 questions you have to do.
I have to read.
Yes, check your heparin. I remember when I was working at BSCC, we had a period that we shifted from 5,000 units per ml to 1,000 units per ml. There were a batch with 1,000. So it was not effective. They used to take by volume, and now it's no more effective, because in fact you give less units per ml. And second thing, be sure that they give heparin. Second thing, what else? Sample time. If you give heparin now and you take it after 1 minute, what will be the effect?
ACT will be low. It's take 3 minutes at least to be.
3 minutes at least you have to do. And then repeat the dose as you said. And if not effective, give fresh frozen plasma, anti-thrombin 3 concentrates. Who is having anti-thrombin 3 concentrate in his unit?
King Faisal.
King Faisal. Okay.
Of course.
And Heparin. Any one of you ever used Heparin?
No.
No. I used it once in my life, but usually you give a fresh frozen plasma and see what's the effect. Anyway, can I ask a question? What is the chance of having heparin resistance? What's percent? Yes?
I don't know the percentage, but depend on the patient. If patient in a chronic use or long period using of heparin or diabetic with insulin therapy, these patients will have high chance of getting heparin resistance.
Heparin resistance, you're right. Those who get used to have, but it's not that uncommon. In some literature, they mention around 20%, which I think is too much, but it's there. Heparin resistance is always there. Those patients who is receiving heparin before going to surgery for around more than 5 days, you expect them to have a heparin resistance. Anticoagulation. Why we use heparin? Because of rapid onset of action, easy reversibility, antidote is available, easily monitor the ACT because you have small machine just beside you, moderate therapeutic window, and few side effects. Absolute contraindication is heparin-induced thrombocytopenia. Low molecular weight heparin have been used in cardiopulmonary bypass, and I think any one of you who want to, it's unfair to ask you about it in the exam, but it's good to have an idea about it. Case number 2, 5 years old girl, partial AV canal, sickle cell anemia from Gaza. And how do you prepare her for surgery?
You check the percentage of hemoglobin S, and if it's less, if it's high, more than 45, you do transfusion, but we call it exchange transfusion.
Excellent.
And in the surgery, you prevent her from getting hypothermic all over the surgery and pre and post.
Okay. So
and you keep her well hydrated.
First of all, before admitting her, expect the difficulty in cross matching. So I advise you to keep her outside, cross match her, because she get used to multiple blood transfusion. So expect this girl to find a difficult matching for her. And second thing, sedate, hydrate, exchange transfusion, keep hemoglobin A more than 60, avoid hypothermia. All this to prevent sickle cell crisis that can happen during or after surgery. Okay, night before surgery, on-call resident told you that the patient is having cold agglutinin. You said, what? You are a surgeon. You are not familiar with it. So anybody having an idea about it? If you came across?
It's hemoglobinuria resulting from cooling temperature.
Yes. But what is the cause? What is the cause? What is the cause of?
I'm not sure, but I believe antibodies that.
Yes, excellent. It's antibodies, excellent.
Yeah, and you should avoid hypothermia.
Hypothermia. There are two types of it: monoclonal and polyclonal. Anyway, is the most important is to avoid hypothermia. That's what we expected to answer. The causes, as I told you, usually due to what? Either new plasma or viral infection. This is important to know, because how to avoid it. Elective surgery should be postponed for several weeks if it is a polyclonal called agglutinins due to viral infection. Once the effect goes, usually they have you can go for surgery safely. Or if a patient is coming for emergency surgery, either use a normothermia or mild hypothermia. And most of them, in fact, they are affected by deep hypothermia. But the only problem that is if you have an emergency surgery in a redo patient, and there is a possibility that you need to, because of injury, you need to go to deep hypothermic psychiatric arrest. This can result in a very serious reaction. Usually, it is in form of reactivation of immune system.
خلي
Inflammatory.
اي بس يغلي يغسل. طيب خلي
عثمان الصوت بس. اوكي.
It's a severe immune reaction that lead to inflammatory reaction to low cardiac output and disseminated thrombosis all over the body. So it's not an thing that you take simply. Case number 2, when you open, you didn't find the innominate vein. So what are the causes?
Most likely it's persistent left SVC.
What is the other cause?
Variant anatomy.
Yes, retro-aortic or left SVC or persistent left. Excellent. How you differentiate?
You look for the left SVC.
Okay.
And you see the size of the right SVC.
Excellent. And when it's slim, cylindrical, it's usually a single jugular vein that descends to the heart as a SVC. How to manage left SVC before starting cardiomyopathy bypass, or if you discover it during the after starting cardiomyopathy bypass? What is it?
Depend on the case. If you're operating on patient and you don't need to open the heart like cabbage, no need to do anything. If you need to open the heart, depend. If there is innominate vein, you can temporarily clamp the SVC. If there is no innominate vein or underdeveloped the right side, you should cannulate the SVC in separate cannula.
A separate cannula, usually a direct cannulation. Yes. But again, if you open the heart and a lot of blood coming to you, what do you do? Is there any other way of cannulation?
Yeah, you can do this, put the sucker in the coronary sinus.
Or retrograde cannulation. What usually I do, I take a bare string on the mouth of coronary sinus and put the vent, another vent, or a regular venous cannula connected to the venous line. Or if the right SVC is well formed, keep the head up a little bit. You can snare it if you have a short operation like a VSD or ASD. Okay, 3 minutes after going on pump, the anesthetist told you that the NIRS is only 20%. What's your reaction? Shabab.
Adjust the catheter position. The cannula position.
What is the normal NIRS?
More than 45.
More than 45. More than. And the somatic? This is the cerebral. Somatic is around 40. But anyway, let's say 45 is the cut point. So what are the causes? What's your action? If the anesthetist is on the head of the table and tells you, please, the NIRS is only 20%. So what's your immediate action?
You will check your cannulas.
Before checking the cannula.
I will look to the ascending aorta.
Before that.
Stop the pump.
Don't stop the pump. Look to the color of the blood coming to the patient.
Yeah. Yes.
This is, and ask the perfusionist about the flow. If the flow is okay and the color is okay, then something else. But if the color is dark, then from where this dark blood is coming? From the pump. Is that right?
So the oxygenator is not working. Or
not only oxygenator, there are other things that we will come to. Now, color of the arterial line and pump flow. If dark, then restart ventilation. If the blood is dark, immediately, and you are not opening the heart yet, or cross clamping, or just cross clamp. Take the clamp out, let the heart beat again, and start ventilation. Fill the heart and allow it to eject. Look to the cause. Is it the central oxygen supply or a gas blender default or sweep gas connection is not connected? All this I have seen it in my life. And the sweep gas flow is not enough or default in the oxygenator. All this you have to know it. And if it's pink, then as you said, check the cannula. Sometimes that the leads of NIRS is not well attached to the baby and give you a wrong result. But the immediate action that I ask you to do is to look to the color of the arterial, the blood in the arterial line, and to ask about the pump flow. Again, you change the oxygenators. You find that the problem with the oxygenator. You change the oxygenator, and I want you to know that what are the type of oxygenator available in the market. No, most of this time, what is the oxygenator available? What we call them? Hi, Shabab.
Membranous oxygenator.
Membranous oxygenator?
Yeah, we have two types, membranous and bubble oxygenator, but nobody using bubble anymore these days.
Oh, since 70s, nobody is using it. And what type of membrane oxygenators? Special type that we are using these days. Okay. Did you hear about hollow fiber oxygenators?
Yes.
Yes.
Most of the time we use a hollow fiber oxygenator these days. Silicone membrane oxygenator is always available. So hollow fiber oxygenator, and usually it comes with integrated arterial line filter and heat exchanger in the same unit. How you see it is like this. Okay. And this layer, this is already cut. And this layer is the 32 millimeter filter is the arterial line filter, which is integrated. Some oxygenators, they don't have arterial line filter integrated, and you have to put it post oxygenator before going to the patient. Case number 3, 1 week old baby presented with a shock status, and your cardiologist he's your friend, close friend. He sent to you with a WhatsApp message this picture, this image. What is this? diagnosis يا شباب.
Transposition.
So, hypoplastic.
Again, yes.
Hypoplastic left heart syndrome.
How is it? This is a normal ascending aorta or diminuted? Answer.
Aortic atrium.
This is a normal ascending aorta. Ya shabab, what is this? Think about it. Is it interrupted aortic arch?
Could be, yes.
Yeah, it's a type B interruption of aortic arch. You have a normal ascending aorta. You have a huge pulmonary artery. And this is the cut of the cut is just showing the SVC, part of the SVC. So what's the diagnosis? So what's the cannulation strategies in this case? Hi, Shabab. Cannulation strategies and interrupted aortic arch. Arterial cannula. What kind of cannula do you have? We will come to that. We have a wire-enforced and non-enforced cannula. We have a straight cannula. We have a curved tip cannula. We have one-piece cannula. And we have vented one-piece cannula. When you say one-piece cannula, what do you mean? Hi, Shabab. When your perfusions tell you that I got one-piece cannula, what does he mean? Is this cannula which is available here is a one-piece cannula? Hi, Shabab. Answer. When we say one-piece cannula, the connection is part of the cannula itself. If you see the lower cannulas are Medtronic cannula, it got a connection which is already there. You don't need to ask for a quarter connection or quarter 3/16 connection. It's already there, so it's one-piece cannula. If it got a lower lock, then it's vented. If it does not get a lower lock, then it's non-vented one-piece cannula. We usually in interrupted aortic arch cannulate the base of innominate artery, and we directed the cannula another from MBA to BDA to descending aorta. You can connect both to a Y connection, or you can connect the upper to the aortic one to the arterial line, and the lower one, which this is my practice. I connect it to the cardioplegia line and cool the patient more the lower part of the body while preparing for the cross clamp and dissecting other part of the aorta. This will take around 10 minutes. By that time, the temperature there is below 28. You can easily clamp the descending aorta and take a long time to do an interrupted aortic arch. I direct the upper cannula toward the innominate. Don't over direct it. Usually these patients have an arterial line right radial and the femoral line, and then you can coordinate between the flow. Keep the flow almost equal in both, but once you go selective flow for the innominate, please decrease it around 60% of the normal blood flow, and keep the temperature within the blood pressure within normal. Oh, sorry. Mention 3 causes that if you see in this diagram, we control the BAs. Mention 3 cases that you need to control BAs before going on BAB. Yalla shabab. Hello. Answer. Three cases, 3 pathologies that you need to control BAs before going on BAP.
PDA.
Truncus.
Excellent, truncus. Again, one case you have it, you see it in front of you.
Interrupted aortic arch.
Interrupted aortic arch till you snare the PDA. Once you snare the PDA, then take the. What else? Something similar to truncus.
AB window.
AB window, excellent. And it's a little bit controversial is the alcab, especially when you give a cardioplegia, then you snare the pulmonary arteries, keep it a little bit tense, then release. So you sure that the myocardium will get enough cardioplegia without get shunted or steal to the pulmonary arteries. Special cannulation technique. This is a 25 years old gear. This is a real scenario. All I wish I give you is a real scenario with a giant right atrium. This is a case 15 years back, have been operated in one of the hospitals in Riyadh and died on table. It's a congenital diverticulum. So what's the danger? It's a virgin chest. The danger that you may not, once you touch this diverticulum, it may rupture and then you cannot control the bleeding. And that's what happened with this patient. And patient died on table. So safe cannulation.
Peripheral.
What?
Peripheral cannulation.
Excellent. Femoral cannulation is a good choice. So mention 3 cases of femoral cannulation in virgin chest. This is one of them. If you have a very huge, giant right atrium that it may bleed and you cannot control it. What else?
A huge aneurysm, ascending aneurysm.
Excellent, excellent. This is maybe the commonest. What else?
Dissection, a huge dissection.
Huge dissection. And sometime
minimal invasive.
Minimal invasive, excellent. These are the main things. Venous cannulation, you can do only venous cannulation, femoral cannulation, sometime in scimitar, or it makes the surgery easier for you because you don't have cannula there in the field of the surgery. Because scimitar always inserted in quite low in the IVC. In fact, retrohepatic IVC. Special cannulation, this is a 18 years old, 90 kg post-arterial switch with a massive aortic aneurysm with a severe AI. This aneurysm involving the aortic arch, you need to replace the ascending aorta and the aortic arch. Then one of the technique is to go and do axillary artery cannulation using a graft. That before you start opening the chest. This is the cannula sizes, and according to the flow rate and according to the body weight that you give you, keep always a chart. If you want to be a pediatric surgeon, keep always a chart in your mobile that you can use it at any time, especially if you are operating in different hospitals. Venous cannula, it could be straight or curved. Most of the time we are using curved these days. And the vent, there are several vents, malleable or L-shaped vent. And this is a very important, especially in a patient with a shunt. But you didn't read this. Hospital, again, this is the flow rate. And this is a very important. Those below 5 kg, you may need to go up to 200 ml per kg, which is unheard of in adults. Case number 4, 37 years old, 34 years post-op repair, coming for BVR, immediately after going on pump, heart is empty, but a low flow with a high arterial line pressure, more than 300. What are the causes of high arterial line pressure and low flow? Already written.
Partially clamped or kinked aortic cannula, arterial cannula.
Excellent.
Malposition of the cannula hitting the posterior wall. Dissection.
Dissection, this is the most important that you should know. And what else? Simple thing.
Small size cannula.
Small cannula.
Small cannula, okay. What else? Your towel clip.
The cannula is too far.
Yeah, I told you, partially clamped or kinked.
Arterial line. Okay, excellent. So these are the things. Once you see dissection, always there. If you see it, it's easy to recognize, especially in adult, and it's a very dreadful complication. If you have dissection, what do you do?
You stop the pump.
Excellent.
And you do peripheral cannulation.
Excellent. And
then you judge. Do you need to cool down and replace, or just if it's confined to the ascending, and you have place to clamp, you can just clamp distal to that and open and assess.
Excellent. Open and assess, and then you may need to repair the aorta or patch it, depending on the age. But the 37, you expect that at this age that the aorta, though he is at post-op, and we know the conotruncal lesion can lead to a huge ascending aorta, but the quality of the tissue most of the time is good, that you don't need to replace the whole aorta. Case number 5, 6-month-old complex AV canal. Yeah, Murtada, do you have a time?
Yes, دكتور. دكتور عبد المجيد طلب نبدأ تقريبا على 3:30. We have 20 minutes. خذ راحتك دكتور.
لا خلاص. 6-month-old complex AV canal. You went on pump, and nasal temperature 28, rectal 38, and you have a high pressure in the arterial line. The flow is around 80%. So, what are the causes?
Most likely dissection.
Okay, how you see dissection? He's only 6 months. Do you see dissection in 6 months?
I'm not sure if it's there dissection in 6 months or not, but usually different in temperature.
Yes.
Dissection can cause different in temperature.
Excellent. This is why I brought this case, to have a different scenario. First of all, what do you do?
You check the nasal and rectal, the
excellent.
Nasal and rectal temperature.
Especially the rectal. Because this is a complex AV canal, you ask the provisions to cool down. So a nasal temperature of 28 is reasonable, but rectal temperature of 34, that means he is not cooling the lower part of the body enough. And this is, you can see in what?
And quart also.
Excellent. In coarctation, an aortic arch obstruction, any kind of aortic arch obstruction. In this case, what you can do? If you are sure that the rectal temperature is well connected, it's in place, you can put what? You said it.
Distal cannula.
Yeah, but what you do? How are you sure that there is a cord?
The difference between the lower and upper blood pressure.
Yeah, could be anything. Could be the cable connection is not. But you are sure that there is a is connected and it's in place. Do you want to put a femoral line?
Yeah, femoral line and measure blood pressure. Comparing
You
to the upper
yeah.
limb.
And then dissect the ascending aorta and descending aorta and the arch, and it should show you a coarctation if there. And this is a real life scenario. It's not something I invented. But these are all real life cases. What else? What kind of aortic arch? Why I said aortic arch obstruction, not a coarctation?
Because interruption will give us the same.
Okay, interruption. Okay. What else? But interruption usually associated 6 month interruption usually associated with what?
With the large BDA.
Excellent, large BDA. But if this patient is not having that huge ductal arch that you see, what else? Did you ever see a surgeon who ligated the arch of the aorta instead of a BDA?
It could be, yes.
Or taking part of the arch at time of
BDA ligation.
Yes, this can happen, and in fact, it's not that uncommon. So when you have a nasal temperature and rectal temperature difference, it's only one figure, but it can lead to a quite large diagnosis that you have to think about it. Why I say the complex AV canal?
Because BDA common with AV canal.
Common with AV canal, even a simple AV canal. But when you say a complex AV canal, that this AV canal, when you see a coarctation in AV canal setting, especially those with the borderline
Down. Oh.
No, we see it non-down most of the time. Arch problem with the AV canal and non-down. We see a TOF with AV canal and Down syndrome. We see left-sided lesion in AV canal and non-Down syndrome. This is why non-Down syndrome AV canal is a more complex to surgically than a Down AV canal. Finally, I want you to know all components of your machine. You have to know all of them. See, every part of your machine can give you a different answer to a scenario that you are having. Knowing what is the custom bag that you are buying and how different connection is there is very important for you to know what's going on. Now, when you go to a hospital, you have only one cooler heater. Either you use it for cardioplegia or use it for the pump. Then use it for what? These are strategies that you have to know exactly when you are going to use whatever there. The trend updates in cardiopulmonary bypass and pediatric, you have to know your tubing, cannula. You have to use venous-assisted, vacuum-assisted venous drainage, tubing diameter, tube coating material. All these you have to know in different custom bag that you have. Priming solution additives, and other issues are very important. Why we are concentrating about cannula tubing side? Because we want a miniaturized circuit. We want to bring the priming solution to the minimum, and only to use a smaller and shorter tubing. Let me ask you, if you want to use a shorter tubing, what does that mean? Hi, Shabab.
You will decrease the priming volume.
What else? What is the technique that you shorten the tubes to minimum?
They bring the machine.
You bring
closer
the
to
machine
table.
closer to the patient.
To the patient. First of all,
To the chest.
toward
To the chest.
to the chest, toward your side or to the other side, opposite side.
No, from your
side.
From your back. Your back. Yes.
That's what they do in at BCC. And then bring the oxygenator and the reservoir up. Is that right? That's what we do. You take the yeah. Usually with every pump there is a clamp. It comes. It's not. Usually, sometimes companies provide it as a. It has 2C shape clamp that if you ask your perfusionist, they will show it to you. According to that, you can increase the level or decrease the level of the reservoir. If you put the reservoir higher up, what is the drawback of this?
You will.
Venous return because of siphonage.
Yeah.
And in this, why we are using a vacuum-assisted venous drainage. It's 20 to 60 millimeter mercury negative. For this, with using it, you can use a shorter tube, smaller even venous cannula. If it is more than 30 millimeter, there is always a safety issue about bubble transgression when the vacuum accidentally reach the oxygenator and pull air bubbles into the blood. You remember we told about hollow fibers.
Yes.
The air, where is in the hollow fiber? Where is the sweep gas flow? It's inside the hollow fibers and the blood around it. And when you have a negative, you suck this air from the hollow fiber toward the blood, and this can result in an air bubble formation in the arterial side. Tube diameters, you have to know it, especially 3/16 when you are using it, and rarely I see somebody is using 1/8, but 3/16 is there. Whenever you use it, be sure that there is the connection that the company didn't throw it, because many times you will not find 3/16 quarter connection to connect your the L part of the loop to the arterial cannula. And the drawback of smaller tube, you decrease the prime and increase the pressure gradient. Let me ask you, and this is a very funny question. Did you ever hear about the M number in the arterial and venous cannula?
No.
M number is a number that indicates how much the pressure gradient at the narrowest part of the tube itself. The lower M number for the same size is the better cannula that you use if you want to compare different companies. And I think next time go and check your cannula and see what is the M number of different cannula, and it's very nice to know it. Coating material, we have 3 types of coating material. Anemia, heparin, and albumin. When you say I want to coat with albumin, you just add an excess amount of albumin in the priming and run the priming before you adding the blood. And this will decrease inflammatory response and decrease the burst of transfusion, especially platelet transfusion. Did you hear about using albumin as a coating material for non-cardiac tubes, for IV tubes before? During your internship, ya shabab?
What I know that they use albumin to coat any surface that the blood will go through to decrease the interaction
Okay.
between the blood and inorganic material.
Excellent. And what else?
And that will decrease the activation of platelets and thrombosis and all these things, and the
And
inflammatory
also,
reaction.
not only blood, and also some drugs like insulin. Some internists, they use, they flush the IV line with insulin, with the albumin before they connect it to insulin, because they say, I don't believe that much, that some of the insulin will precipitate in the tubes, and so your calculation of the how many units is not right. This is the custom bag. Did you ever unpack the custom bag before? Shabab.
I
No.
did once.
Huh?
I did once with the perfusion.
I think, yeah, I think better at least to know what is there. Usually be accustomed to it whenever. Many custom bag come with a 3 suction connections, one green, one blue, one red, depending on the unit you are working. It does not cost a lot, but it can save for you a lot when you are going to use it. Thank you. I think this is, any question?
Thank you. الله يعطيك العافية.
الله يعطيك العافية.
I tried not to make it a classical cardiovascular lecture.